Good morning, everyone. My name is Anand Kumar. I'm technically a geriatric psychiatrist, and I've worked with Alzheimer's patients mostly through teaching clinics at this point. And a lot of my earlier work was related to neuroimaging, starting off with PET scanning in Alzheimer's disease, MRI in Alzheimer's disease, and subsequently at the interface of depression in late life, which, as you know, is risk factor for dementia and cognition neuroimaging findings. So what I'm going to do this morning, I want to thank the organizers for inviting me, Igor, Dr. Doraiswamy, and thank you all for you're such wonderful hosts here in the Duke campus in North Carolina. My goal, I enjoyed many of the presentations yesterday, all the ones that I happened to be around for, and learned a lot from all the data scientists and the rigorous work you do. My focus this morning is going to be a little different. It's going to be about, as the title says, biomarkers, trying to distinguish between biomarkers and therapeutic targets, and talk a little bit about clinical significance versus statistical significance. It's become a larger issue these days. I will be making a few comments about the drug approval processes for dementia, with special emphasis on the drugs that desperately seeking approval or the ones that have been partially approved. Some comments on the process and can take it from there. Thank you. So that's the presentation, the topic. This is the famous, I'll start with a little bit of history. This is Dr. Alzheimer. For those who may not be very familiar with his history, he's a psychiatrist who was born and raised in Germany. And when he was in Frankfurt doing what we would now call a residency, at least we would call it a residency, graduate medical education in the United States. He did part of that. It was an institution called Ouch. I guess it's me. And while he was there, he was asked by the superintendent of the institution, Professor Scioli, to see a patient, this patient, Augustine. She's the first known case of Alzheimer's. She was admitted for a course of illness that was about 6 to 12 months long. It started off with suspiciousness about her husband, and subsequently, when he found it difficult to manage her at home or impossible to manage her at home, he got her admitted to what we would now characterize as a state hospital. Dr. Alzheimer was a resident who was looking after her, and he's made some very elegant notes on the presentation and symptomatology. Significant language difficulty, she had trouble expressing herself, had some difficulty understanding him, and over the course of a stay in the hospital, her memory declined rapidly. This is a quote from William Osler, the famous physician, one of the founders of Johns Hopkins Hospital. This is not about this patient, but about aging in general. Touch with a slow finger of time, the nutrition of that thin layer, and backward by a slow degree, treat the intellectual faculty, back to childish simplicity, back to infantile silence, back to the oblivion of the womb. Also, I may have overstated a little bit, but nonetheless, that's what happened as per the description to Augustine. Dr. Alzheimer moved on. He moved to Munich. There he completed his residency and took up his first faculty position. He was working in the laboratory of Emil Kraepelin. Emil Kraepelin is the father of, many consider him to be the father of modern biological psychiatry. Now, that is a very interesting school of psychiatrists in Munich. Remember, this was at least 50 years before psychopharmacological agents were available. So all they had was the ability to describe disorders and their longitudinal course, which Dr. Kraepelin did remarkably well. Many of them who trained in Dr. Kraepelin's school were also pathologists or histologists. They received training in histology. So this is how the first pathological, neuropathological study of Alzheimer's disease and slides were made. This was an amazing school. It included people like Nissel, those of you who know neuroscience would know these names, Nissel, Golgi, etc. Huge historical names in neuroanatomy and histology. Many of them are also trained in clinical psychiatry or neurology, and part of the scope. So when Augustine Eder passed away, when she was in Frankfurt, Dr. Alzheimer had moved to Munich. The hospital sent him essentially the brain for postmortem analysis. He had all the clinical features, and this is a postmortem analysis. Now, this is not Alzheimer's slide, this is from the Holtzman and Science Translation Medicine. So let me talk about two proteins that he described then, which continue to be the focus of attention and in some ways baffles the scientific community. These are the famous plaques, diuretic plaques, A-beta 42 amyloid, central protein surrounded by glia, neurites, inflammatory markers. Much of what we argue about today, discussed and focus on, was initially described by Dr. Alzheimer in 1906. This outside the neuron, these are tangles, tau. This is A beta and other things. This is tau, phosphorylated tau within the cell. This is what you would see under the microscope, plaques and tangles. This is necessary. Until very recently, you needed a clinical course that was consistent with Alzheimer's, together with neuropathological evidence of Alzheimer's, obviously early postmortem. What's called the old NIDS, ADRDA, old names for the institutes, a definitive diagnosis of all that. You could, the clinical diagnosis would be probable. Now there have been subsequent changes to it. This is again historical. So in 1906, Alzheimer presented Augustine Eder the case to a group of psychiatrists in Tübingen, Germany. Single case report. Now we're told how unimportant case reports are and you need large sample studies. That's true for many things. That was just a single case. After he described the case, the clinical features, and the postmortem findings, the chairman of the session turned around and asked the audience if there are any questions. There were none, at which point he turned to Dr. Alzheimer and said, and I quote, "As you can see, Dr. Alzheimer, there is no interest in this case." Famous last words. It was considered so insignificant, a single case, that the organizers of the conference refused to publish it in the proceedings of the conference. The Tübinger Chronic, the local newspaper, had one sentence saying Dr. Alzheimer described the case. It's one sentence. Nothing much came of it. Many years later, that was 2006. Much later, he presented two cases. Illustrations were Alzheimer showing irreparable tangles and amyloid plaques, including 1911 articles describing Augustine and psychiatrists, Johann M. Plaques, tangles. This is a photograph of what he originally presented in this paper. Now, all this is, I'm leaving up some. I'm trying to sort of lead to a good ending. These are the tangles. Drawings of irreparable tangles by Alzheimer and published in 1911. This is what he's doing. Plaques are clustering and tangles these elongated proteins. Okay. Which leads us to a question of what is a biomarker? Now, there are many broad, fancy, elaborate definitions for biomarker. But let me tell you a very practical one. A biomarker is a laboratory-based measure that can be used to, one, diagnose a disease, two, monitor a disease, meaning progression, and three, study the impact of an intervention on it. The classic example, the best known one, is hemoglobin A1C. Yesterday, some of you presented data on hemoglobin A1C from Medicare, sort of payment records, EMR, and so on. The A1C is necessary for the diagnosis of Alzheimer's disease. It's also used to, of diabetes. It's also used to monitor diabetes. So one of the first things, other than glucose, if you go to your primary internist once every 3 months, 6 months, whatever, I think they would check the A1C because it's a measure of glucose control over the past 3 months. Sort of an area under the pill kind of concept. It's high, it's above 7, your diabetes is not under control. Above 9, it's very poor control, and below 6, very good control. But the medication is not used to treat A1C. Insulin and other oral hypoglycemics are used to treat a disease process. What A1C is a biomarker. So you have what's called a pathophysiology, multiple processes here. It may be atrophy, molecular changes, inflammatory changes, and then you have a biomarker. The closer the biomarker is related to the primary pathophysiological process, the more reliable it is clinically. But the biomarker is not the same as the underlying pathophysiological process. This is where I think some of the confusion in the field, I may be overstating it a little bit, but the difficulty in distinguishing between a true biomarker and a true pathophysiological process. I think that's part of the challenge we have, and I go on to describe some of it. The two principal biomarkers for Alzheimer's disease remain what Alzheimer's initially described. Some variation of the A-beta 0.2, etc. You can measure it post-mortem. You can actually see plaques. In vivo, in the living state, you can measure it using positron emission tomography PET. You can do it in the cerebrospinal fluid. And it's likely that we'll have a more accurate assay to look at it in the blood within a year or two. It's available, but less accurate now. All measuring the same thing. And unlike other branches of psychiatry, there's a good correlation between brain PET and CSF findings of A-beta. So this is the principal biomarker. Positron emission tomography using what's called PIB, Pittsburgh compound. There are many other compounds now, binds to plaque. There have been areas of orange and red, a high PIB binding. Let's compare the extreme first, the control patient, Alzheimer's patient, and this is myocardial impairment, almost a pre-dementia stage, where patients have substantial memory loss without the other cognitive elements, language, behavior, etc. And very often, what's called the amnestic MCI is a slippery slope. Conversion to Alzheimer's. If you can diagnose accurately having amnestic MCI, about 15 to 20% convert to Alzheimer's every year. The main point here is as you progress clinically, you might use. This is William Plum, the psychiatrist at the University of Pittsburgh, first with this imaging study. Chuck Mathis is the chemist who developed the compound. My colleague at UCLA at that time, Gary Small, developed a somewhat of a similar compound called FDNP, which binds plaques and tangles. This is cerebrospinal fluid, tau, and CSF. So let's go to tau. Controls, Alzheimer's. Again, there's no perfect separation, but considerable separation. Increased phospho-tau in Alzheimer's patients, lower in controls. CSF, we find an interesting situation because the way plaques, amyloid drains from the brain, it's lower in the CSF. Alzheimer's patients have higher A-beta in the brain, but lower CSF amyloid. But it all tracks together. This is the case in neurobehavior that there are very good biomarkers that have been used. There are multiple papers, Dr. Klump's group, Dr. Small's group, and now many others showing baseline differences between patient and controls, tracking patients from mild dementia to severe dementia, the binding goes up, and also tracking people when they're normal, even before MCA, asymptomatic does. Higher the baseline binding, over time, if you follow them, they're more likely to transition in dementia state. So these meet two of the criteria of all that. Useful in for biomarker, useful in diagnosis, and useful in tracking the disease. So this is the paper that I happened to write along with several colleagues of part of the APA, American Psychiatry Association Biomarker Task Force. This is the question you ask. Are these biomarkers, as we understand biomarkers, i.e. hemoglobin A1C in the brain of Alzheimer's, are they true therapeutic targets? Because they were described over 100 years ago and remain the focus of attention, this question has never been clarified. People have sort of assumed, without explicitly stating so, that they're both. Yeah, they're biomarkers, but they're also responsible for disease. There has always been, I would say, a significant minority, oxymoronish as that term might sound, who stated that these amyloid and tau are not pathophysiologically critical. That they may be markers of a regenerative process in the brain. They don't have that much evidence for that either. but nonetheless, there is the bulk of the evidence, the bulk of the scientific community believe that these are therapeutic targets. So does the pharmaceutical industry. And they followed the scientific lead. Scientists in different laboratories said, this is it, amyloid, and came with a lot of data. And the goal over the last 20 years, 25 years, has been to develop compounds that remove amyloid from the brain. This is what I would consider a slippery slope. Let me transition a little to the FDA. So the mid-80s, during the height of the HIV/AIDS crisis, there was considerable pushback from the community, not just advocacy groups, but patient groups saying they need some treatment. They cannot wait for science to eventually play out and come up with a compound. So under pressure, the FDA developed what's called the Accelerated Approval Program. Now let me go through this because this is now the center of many of the controversies that we're dealing with. It's used for a condition that is serious or life-threatening. The approval is based on substantial evidence of an effect on a surrogate endpoint, meaning a drug can be approved even before there's considerable evidence that the drug works clinically, based on a surrogate endpoint, i.e. a biomarker. This could be a lab measure, like the CSF tau, for example, or a radiographic image, which could be a PIB binding of A beta in the brain, or a physical one, the clinical endpoint that can be measured earlier than the full resolution. But here's the most important part. The surrogate is likely to predict clinical benefit. So it just cannot be a biomarker that is disconnected from clinical benefit. This is the third important criterion for a biomarker. Going back to a somewhat simple but direct analogy, the A1C. If you have insulin, blood sugar drops, and you have insulin, take insulin for 3 months, your A1C will drop. It's very, very clear. That's why it's a reliable clinical biomarker. This is where we have a problem. We're now using a biomarker as a therapeutic target. So let me go to, so everything was under the radar. People, demurred, mumbled, grumbled, etc. Then came a compound called Eduta, produced by Biogen. The data that FDA approval, you need 2 positive trials, 2 trials showing that the active drug is better than placebo. Biogen conducted 2 trials. They stopped the trials before it ended because there was no effect. Statisticians went back, looked at one of the trials and said, if you look at the data, the higher dose is associated with some clinical impact. These data were presented to the FDA advisory committee. 11 members of the committee, one said they didn't know how to vote, 10 voted against approving based on the clinical data. The data were then sent to the FDA larger committee. What the FDA larger committee did was they looked at PET binding data of A beta, which was not shown to the early advisory committee, and said, let's use a different mechanism to approve this. Let's use the accelerated approval model, meaning just based on the biomarker. Though the drug shows no clinical effect now, we'll say it's promising. 3 of the 10 members resigned the advisory committee, saying, first, the data was not shown to them. Secondly, that's not the basis of approval. It doesn't fit those criteria. The drug is approved by the FDA, accelerated approval. Center for Medicaid Services, after much consideration, after a lot of feedback and pushback, decided not to fund. So this is Pam Muller of New York Times. Ever since Medicare proposed to sharply limit coverage, the controversy all that is already written out. The agency has been deluged with impassioned pleas. On Thursday, this is page 2. Medicare officials announced their final decision. So the Food and Drug Administration has approved their bill for 1.5 million people. Medicare will cover it only for people who receive this participants in the trial. Essentially, they said Medicare will not pay for this drug, except if you enroll patients in federally approved trials. You'll pay for that because the data are not there. This is very rare. It's unusual for CMS to say we will not cover a compound that's approved by the FDA. I happen to think this is the right thing and we'll go to that in a minute. Shortly thereafter, another study, similar, the monoclonal antibody reduces. By now, industry is highly committed. They're slowly moving away into diversifying their portfolio. This is a Lilly-funded study. Most of the investigators here work for Lilly, but it's a multi-center trial, published in the New England Journal of Medicine. Similar in approach. Let me show you two graphs. This is one of the metrics used, many metrics used. Those who have clinicians, if all of you take tests, you get that's the maximum you can get. Orientation items, basic orientation items. Some of you showed these items yesterday. A terminally, patient with terminal dementia, quote unquote, will get 0. You won't do that. And look at this. After over a year, close to a year and a half, both groups decline. This is an significant benefit. For those of us who you see patients, etc., or even otherwise, these are not real cases. But look at what the PET scan shows. This is the group that got placebo. No change in brain PET. This is the group that got the active compound. Close to 80% drop. So let me go back. You see virtually no clinical difference between groups. But you see a substantial difference in A-beta binding. So the presumption that this is linked, in order to get approval, accelerated approval, the biomarker needs to be linked to the clinical response. This does not happen. This is a direct quote from the immunity. There was a greater reduction in the amyloid plaque level in the donanemab group than in the placebo group, for which we were unable to show an association with clinical outcomes at the individual level. For most secondary outcomes, differences between the two groups did not provide evidence of predictors. Yet they pushed for approval, saying it's promising. You approve the other guy. That's one risk of these one. Once you set a precedent, others will say the same thing. I've shown reduction actually. They showed a significant difference now. But the issue is that connected to clinical improvement? Is the, in other words, a biomarker or a therapeutic target? Now, this is the latest drug that is causing somewhat of the same group. Again, published in the New England Journal, that's all very prominent researchers, they all have a field. Dr. Van Dyke is a psychiatrist from Yale who does a lot of imaging, Paul Eisen, some clinical trials. So now the scales of the group, they use a different scale. And all these studies published within 6 to 9 months or more. Projects have been going on for a long time. This is what we use the sum of boxes, clinical dementia rating, 6 domains: memory, orientation, judgment, problem solving, community affairs, home and happiness, person. So you can get 0 to 3, 1, 2, 3, each of these you can score them. And this is from an archival neurology paper about the same CDR as sum of boxes. You get 16 to 18, severe dementia, 0 is normal. So all of you get normal. Severely cognitively impaired patient close to 0. Now the difference, they showed statistical significance. They argued in public, initially in a press conference, that there was a 27% difference. But when you look at their data, look at their own paper, in fact, I read it again this morning before coming here, nor in this quote anyone. Difference is about 0.4 of the 18. 18 points you get in this score. Difference is 0.4. Based on that, here, the Canada placebo. It is not as bad as the previous one, for sure. It is still a very, very small difference. Patients will not notice difference over 18 months. Family members will not notice difference. Out of 18, 0.4 is very small. 0.375 is what the Indian paper says. But my point is not to quibble about 0.375 versus 0.4, is that the differences are very small. Yes, there's a difference. The first drug ever, amyloid lowering drug, showed the difference, but the difference is very small. Now, there have been dozens of anti-amyloid trials over the past decade, literally dozens. All of them have failed. By simple law of averages, someone's going to come get through. Look at the difference, it's small. But look at the difference in time. significant. About 60% in one, 0 in the other. So these drugs do what they're supposed to do. They lower amyloid in the brain, but they don't do what people hope they would do, which is result in clinical improvement. This drug was again early approval by the FDA. CMS is still very concerned and they're looking at the data for the approval. I say this not to mock anyone. There's tremendous need for these drugs. There's tremendous need for the treatment of Alzheimer's. There's no doubt. There are 5 drugs in the market today approved for Alzheimer's. 3 of them are cholinesterase inhibitors, chemicals, drugs that increase the level of acetylcholine in the brain. 2, one of them acts on NMDA, particular receptor, NMDA modulator, they call it, and the other one, 5th one, has a combination, both drugs. All of them slow progression, at least as much as this drug does, some argue even more. So there are drugs out there, which are cheap, inexpensive, generic forms are available. They have some side effects, but no non-threatening side effects. Plaque removals have edema, brain hemorrhage, a higher percentage than placebo, and they're very inexpensive. This drug would cost by estimate about $26,000 a year. It requires an intravenous infusion every 2 weeks. It needs to be closely monitored. And 17%, 12% difference of edema and brain hemorrhage patients versus controls. These are significant side effects. The Lancet, in an editorial titled Temporary Hypno about lecanemab, basically said, they said it's 0.05 difference on the CDR-SB, that is, some boxes might not be clinically meaningful. Minimally clinical important differences for the CDR-SB was 0.98 for old people by cognitive impairment and 1.63 patient by Alzheimer's. And they conclude that the lecanemab game changer, as someone suggested, remains. The changes are small, is the main point, and one needs to be very careful in looking at imaging findings and saying, wow. So I've written several op-eds on this, and this is on the more recent ones about the new drug, saying we shouldn't get caught up in hypo, the Alzheimer's drug. Now, as those of you who have written these opinion pieces know, the title is always chosen by the publisher. And they try to get the most catchy, provocative title so that people will read. It's the hook, the sizzle that sells the stage. But these drugs are not what they might appear at first blush. Are they a path in the right direction? Yeah, I would agree. I think there is, considering that dozens of these drugs have failed, it's worth investigating. But investigation should be done with it in a clear-eyed manner. So what's the take-home message? Statistical significance versus clinical significance. What's happening in some of these studies is that, as many of you know, biostatistics and epidemiology very well, studies are overpowered. The lecanemab study had about 850, 870 patients roughly each group, which is very big for Alzheimer's. The early New England trial will show there were 250. Smaller, but still high. With such large samples, you can pick up differences that are small. They become statistically significant. The real issues are the clinical. It is possible to gain this. It is possible to pick markers early on and say, well, a priori, we predict that there will be a small difference, and that's clinically significant. But some of the differences are not clinically significant. That's the problem. Drug is expensive, and there's tremendous pressure to get these things. Rigorous standard for amyloid cognition proof of principle. Proof of principle that reduce amyloid in the brain, cognition improves. I would say it's still unproven. Of all the dozens of cases there and decades of history, in the 80s and early 90s, there's a Hopkins psychiatrist called Marshall Polstein. Polstein and Present had many papers published showing when patients are given physostigmine to the compound that increases acetylcholine in the brain, blood flow to the brain, blood flow is a biomarker. Now specific on that improves. Cognition does not change. So changing biological parameters in the brain with compounds have been demonstrated. What has not been demonstrated is that is associated with clinical improvement. That's the case. I think you need to compare efficacy with existing treatments to see if this, provides the basis for approving new drugs. Are they sufficiently better than oral drugs that are inexpensive? Community-based effectiveness studies need to be done. That's what CMS said in the case of the drug. We need more community-based studies. If you're seeing increased edema and hemorrhage in a very well-screened clinical population, you need to know, have some sense of how it will impact the community, but you're not going to have to take I would say separate public pressure from scientific. Everyone means well, including critics like we all want to stay. We all either have friends, family members, relatives, patients, and their families who are struggling with disease. But the question is, how clear-eyed, how objective are we going to be about the new drugs? You stop there, gone over by a minute. Thank you for your attention.
Any questions? Yes.
Yeah, Dr. Hussain.
Well, first of all, congratulations, Dr. Kumar. This is obviously a complicated question. It's a controversial question, and to have the courage to bring it to light. The reason I'm bringing it up is the cost. The way it is being at least marketed, costing about $25K a year. I mean, it's going to drain Medicare and CMS. It's not just in this population, but overall. And as a clinician, I can tell you there are pressures on the families, from the patients who are almost demanding, oh, this is a drug now approved. Why don't you prescribe it? How do we handle this?
Well, that's a good question. It's a very good question because clinical trials have been going on for a long time. There is no simple answer to this. Part of it has to do with the first presentation of data, not surprisingly, I guess, occurs at a press conference. That's what all these companies do. The first thing is a press conference saying this works. Second is a presentation at a scientific conference, and third is the publication. By then, everyone's all excited. The Times of London actually talked about the new drug, lecanemab, called it the beginning of the end of Alzheimer's. Enthusiasm is understandable. Such hyperbole can be misleading. How you would deal with it, I think it's hard. I think there are existing drugs. People have forgotten about 5 existing drugs. They do the same thing. The cholinesterase inhibitors that are out there in the market. Now, an average cholinesterase inhibitor, the generic version, costs about $2,000, roughly, which is this costs $26. This also requires $26 just for the drug. Then you bill for physician time, you bill for neurologist time, you bill for MRI scan, it all adds up. As per current rules, FDA does not have to factor or is expected not to factor economic considerations. Their mandate is different. Center for Medicaid Services, on the other hand, has to factor. That's part of their role. Is to look at broad clinical impact of what they do, including devices, etc., and to see what the cost is. They do have a responsibility to Congress and to the taxpayer ultimately to see if this is going to change the clinical state. Because remember, the first thing that happens when a drug is improved is Medicare premiums go up. Yes, so there is a tension among those of us in clinical practice to say, should we really consider, how does it matter to us? We should only help patients and their families and suffering in some form, diminish it if possible. Not worry, let somebody else worry about the cost. But that said, if these drugs did something noticeable, even if it didn't reverse cognition, which would be the ultimate goal, but it slowed it down much more than this, much more than existing drugs out there, it would be worth the fight, for sure. But that's not happened so far. So I think, to answer your question, it's a complex, one. There's no simple answer. Educating families about what's available and how the newer ones not better, maybe even marginally inferior, and associated with a little more risk. Just go with the data.
Just to follow up, please. You are the chair, so you can keep the time.
Well, I'm going over. I'm abusing my chair privileges.
The question is, but if you look at the history, HIV treatment started with one drug. It didn't do much. Once they moved with the combination, we are almost at a point that we are completely treated, not cured HIV. Couldn't this be a step forward towards that?
Yes, HIV is a great example of how science helped public health, without a doubt. That said, these data at this point, we're not there yet. You could get there with further science. You could also get there by diversifying research efforts and not largely focusing on analyze. There are other markers, tau is one, inflammatory biomarkers, other pathways. This has become the great white whale. And all of us are sort of the Ahabs of the world, saying that's it, you're going after this, no matter what. That is tricky. I mean, the large segment of the Alzheimer's scientific community focus. I want to pick my words correctly. So I haven't picked them as carefully yet. Has considerable amount of investment in a compound that may or may not work. It becomes a problem. But yes, hopefully things will get better. There'll be newer compounds that substantially not just slow the progression, also reverse cognition. These will be wonderful things. But we only have the data that's put before us. And those data were published data. Thank you very much. I'll be around if you want to.